Not a branded one. This is 1 HP.
Okay. It's normal regular suction only.
Not a regular one.
So you are removing roof.
Yes. So I am further widening by means of a through biting anteriorly, not behind, not posteriorly. I may damage the septal branch. And it looks adequate. The sphenoid had, unaeration. You can see the state of the mucosa, which need not to be removed. See this edematous? It will revert straight. It will revert when the steroid solution goes. See this picture? Orbit as a lateral wall, terminate. We didn't disturb at all.
Excellent, sir.
And the
Dr.
field is
Satish,
good.
can you show us how you pack now?
What?
How you pack the nasal cavity? How you pack it?
Pack
One
it.
by one.
Okay. Let me first irrigate me for the part. First, we wash it thoroughly.
Sir, any advantage you feel in using RL? Yesterday I
Yes,
was
RL is more physiological than NS.
any bleeding control or bleeding is
No,
also.
bleeding has nothing to do with that.
Okay.
Bleeding has nothing to do with that.
Sir, you will mobilize the middle turbinate back to the position, or you will leave it like that?
I didn't do anything to middle turbinate yet.
No, but
I
after
told you, see, marrow cell, same marrow cell, soaked in steroid, and you can keep in the cavity like this. That's it.
Okay.
See this?
this
Yes,
is mirror cell soaked in
And one
steroid.
more, if you are doing septoplasty or anything, you can keep one more, a long pack on either side in the nasal cavity.
Okay. And after 48 hours, you take it off.
Yes. So that's how one side is done. Other side, I'm not showing. We are coming there. That's all.
Thank you, sir.
Thank you very much. Thank you.
great.
हम कर दूं, ये कर दूं। टटवा आ रहा है इसके पीछे। ये आ रहा है, छोड़ दे। अर्जुन 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 कर। So, any questions? This was the CT scan of this patient. I forgot to show you.
Thank you, sir.
Welcome, sir. Coming there. You. Hello. Hello.
Hello, sir.
Yes, that is the CT scan of the same patient which just operated. Just forgot to tell you, show you before. So that's a classical one, agar. We saw the agarneji, this one, and the maxillary regular one. Sphenoid, see the regular one with little mucosal edema and all that we have seen, but nothing significant. What was most of the thing is opacity because of the polyposis. So this was the surgical session, the first session of the day, and we can continue discussion on anybody having any doubts in the mind. What I believe after going back, you should be able to do all these procedures with the backup of understanding of chronic rhinosinusitis, what we discussed yesterday, what kind of a disease is, what kind of a patient is, any immunological, any microbiological, all those determinants, allergy, asthma, this, that, endotypes, everything has to be taken care of. And with that backup knowledge, if you treat, I believe nobody can stop you. And this is all these procedures, even the draft procedures, I believe you should be able to do it. There is no challenge. Only thing is the equipments and the zeal to do it without any fear. The draft is the area, the frontal sinus where we are operating is the safest zone. The only challenge is skull base, which is determined by the olfactory neuron. Don't go behind that. and do anything what you want to do. Initially, you may give some damage to the skin or anything that may give buttonhole or anything. That's not a big complication. You can put a suture outside, nothing more than that. But that is a very, very safe zone, and you can practice in the cadaver also sometime to get used to that anatomy. And that the best part is the entire process is done by a 0 degree telescope. So you don't know sort of disorientation one can come across easily.
Excuse me, sir. Sir, can you elaborate a little bit more on cripple sinus, which you had put up? And also, there was this mention of facialization of frontal sinus.
Okay, facialization I had already mentioned. I can show you again. The cripple sinus was the same I was saying, like for the frontal I had shown you. Frontal I had shown you the various procedures, draft procedures, modification of the draft, then cranialization, facializations. All these are the procedures which are required for the, in the most difficult situation. Like the patient we operated draft 3 today. If she comes back, if the sinus doesn't maintain, drainage and still giving problem, we have to think beyond like cranialization, facialization, depending upon it. The facialization is when the anterior wall is eroded, remove whatever left anterior wall and remove all sinus mucosa, drill away until normal bone, block the frontal recess outflow, and allow the front outside skin to fall upon the posterior wall. It may give a defect which you can reconstruct with a bone cement. That is successful provided you don't leave any mucosa buried underneath. So the first foremost thing is the mucosa removal. Complete radical removal of the mucosa is the priority before doing anything such. For maxillary sinus, there are sometimes challenging situations like hyperplastic maxillary. Be careful on CT scan. In this situation, what happened? The uncinate is very, very close to the orbit. See on the opposite normal side, the distance between this is uncinate, this is the, this part is the orbit. And I always tell this is the closest structure to the orbit, but in hypoplasty, even it becomes more closer. If you try to use, your sickle knife or anything to remove the uncinate, you're likely to enter into the orbit at the beginning of the procedure. So this is something not warranted. Some more thing about the maxillary sinus wanted to tell you. Okay, for maxillary sinus, sometimes you have a disease like yesterday you saw the trephination, the canine fossa approach. Though in maxillary sinus, what happens sometimes you have after the revisions, multiple revisions, you have a kind of a fibrotic sinus with multiple cavities, non-communicated to the, the drainage pathway. And you really need to remove all that, give a wide drainage. You need angle instrument, canine fossa enterostomy you can undertake, medial maxillectomy, pre-lacrimal approach. All these and ultimately leads to obliteration if the fibrosis happens. So there are certain cells which poses challenge. We pose challenge in the maxillary sinus. This is the Heller cell. Yesterday you saw the same Heller cell. I removed this partition to communicate with the maxillary sinus. Sometimes you have multiple Heller cells. You see it narrows your infundibulum. Be careful. Otherwise, sometimes you are lost. And sometimes even if you have a bigger cell, you open the sinus, you remove the uncinate, you look like you open the sinus, which is actually a Heller cell, and you ignore the maxillary sinus. We have seen Heller cells even much beyond this, bigger than the, maxillary sinus itself. So there are variety of situations. You have to be careful. Then this is canine fossa enterostomy. I had shown you yesterday. Already shown you. This is 1 centimeter above your debrider, a 40 red directly without any cannula. It comes directly inside and you can really somersault this everywhere, 360 degree with a 70-degree scope in view. And you can, you can reach out each and every nook and corner of the maxillary sinus. And much more comfortable way, and it is not associated with any complication or so. In a massive situation, you may have to do a medial maxillectomy. So, what I want to say overall, the CRS is a complex multifactorial disease. It's not a simple disease. You can compare it like any syndrome, you can say, where multiple things are contributing to the severity of the disease, and it's not a simple situation where one can think of getting away all cases in a similar way. So it's a multifactorial disease, and the basis of a good overall outcome is understanding the pathophysiology, wherein we discussed a lot of things yesterday. That is the pillar of the success for the treatment of this disease. We need to know this disease in detail, and there are phenotypes and endotypes of this problem, which you must know. It's a medical disease. Don't forget, it's not all cases require surgery, and appropriate medical management is the core, except some exceptions which I mentioned yesterday, which are direct surgical candidate. And once it comes to surgery, an appropriate, surgery should be directed with keeping in mind preventing minimal to minimal level complications. That is the most important thing in the surgery, which we have discussed both these regarding the surgical part. And I'm coming there to discuss the post-operative, and the irrigations are the mainstay of the long-term outcome, because the topical steroid is the core treatment nowadays. Targeted therapy, of course, is the future. But still, in spite of understanding a lot of things, in spite of success in the surgery, in spite of advancement in the surgical technique, instrumentation, everything, we have still long way to go. Still, there are, tests needed to know the microbiome status. There is no clinical test to know the status of the individual patient's microbiome, immunity level, the biofilms. There are no clinical tests in the market to detect biofilms easily. No clinical tests to know the genetic status and the genetic factors predisposing to the sinusitis. And of course, biologics is the future, where this is going to take over these clinical manifestation, and we can curb the disease in the earliest way, at the earliest point, by targeting, at the molecular level. So this is about the sinusitis we need to understand, and still, as the science is evolving, we have to do more and more better, keeping the pace with the advancement in the medical science. And I hope once these core issues are solved, we'll be in much better position to treat this disease, in the future. Any questions?
Sir, if during surgery, if we see the lamina pepracia and we accidentally break the lamina pepracia and we see fat prolapsing, so what care should we take?
That's what I'm coming to. That's the now last two sessions are aimed at the post-operative care and complications, managing complications. So, yes.
Just I wanted to know, you were talking about inferior turbinate. You have told there is you did denervate the inferior turbinate. Can you show any video or something here?
Yeah, that is simple. I could have shown you posterior nasal neurectomy. See, innervation means post-ganglionic supply to the glands in the inferior turbinate leading to hypertrophy. So basically, the nerve supply comes to the post-ganglionic, to the glands in the inferior turbinate, comes to the facial nerve. Facial nerve giving a branch GSPN, which is basically a continuation of nervus intermedius, and GSPN continues to the foramen level, joins the deep petrosal nerve, and become the Vedian nerve. Vedian nerve coming to the pterygopalatine fossa, joining the pterygopalatine ganglion, and from there the postganglionic fiber, the posterior nasal nerve, come in the posterior part of the nasal cavity through the pterygoid, perpendicular plate of the pterygoid plate and the sphenopalatine foramen, and those nerve filaments enter the turbinate to supply the postganglionic, to the gland supply to the gland. So if we target those postganglionic fibers, we can reduce this glandular stimulation and hypertrophy of the turbinate. That is what I mean to say. What you can do, use a cobblator in the region where those nerve fibers come to the inferior turbinate. So in the posterior part of the nasal cavity, those fibers come to the mucosa. The mucosa between middle and inferior turbinate can be cobblated to automatically coblate those nerve fibers, making them non-functional. And it really helps in, dealing with the, soft tissue hypertrophy of the turbinate. Bony
It's
hypertrophy, you can do a partial bony resection. That is
Okay.
what I mean to say.
But we have to do exactly just behind the maxillosinus ostium, or it's just
Yeah,
behind
behind the
the
maxillary sinus.
posterior-
Behind the maxillary sinus. Where the
Okay.
perpendicular plate of the palatine bone is, sphenopalatine foramen is.
Okay, okay. Is there any role of Vidian neurectomy or something?
So, median neurectomy. See, what fibers we are targeting? Postganglionic fibers which are carried through the median nerve and delivered in the pterygopalatine ganglion, and from there, the fibers which are destined for the nasal and palatine glands, we are targeting them. Now, if we target the median nerve before coming to the ganglion, that median nerve contains the postganglionic fibers to the lacrimal gland also.
Okay.
We can unnecessarily give a dry eye, which can happen in certain percent of the patient. Why to?
Yes, sir.
We have to do a
sir.
selective denervation by means of targeting the posterior nasal nerve.
Is there any role? Earlier we used to say, like in sympathetic vasomotor rhinitis cases, you do Vidian neurectomy or something.
Yes, so
it's gone now.
When this science was not developed to the level of understanding of the posterior nasal nerve, video neurectomy used to be answered, and the
Okay.
commonest complication would be the dry eye, which has
Okay.
stopped us from doing, operate kare main samjha. The commonest complication has been that, and that's why it has not been, very, very popular surgery. It has been disregarded after that because of this complication. The posterior nasal neurectomy, yes, you can accomplish without any such severe complication.
How common you encounter vasomotor rhinitis, sir, in your practice?
I can't say. Most of the time it goes undiagnosed. The symptomatology is so overlapping.
Yeah.
So I can't say in terms of percentage, but yes.
Is there
there
any
are-
direct test or something? We can
Not
diagnose?
really.
Because it's
It is just-
it's a very overlapping kind of a thing.
Yes. But by and large, the treatment is same. Yes, in that situation, if you do a posterior nasal neurectomy, it is more effective. That much I can say.
Thank you. Thank you.
Excuse me, sir.
Now,
Sir,
Hello?
while doing sinus surgeries, is there any point to note whether it is of tubercular etiology, like later on, sometime there is persistent discharge and then we get gen expert done?
in
Some sort of
paranasal
tuberculosis?
sinuses, we have encountered tubercular sinusitis. Chronic granulomatous diseases have many, differential diagnoses in the nasal cavity, like chronic aspergillosis present with granuloma. So many other chronic pathologies which can present with granuloma, rhinoscleroma, Sjogren's, so many things can involve the paranasal sinuses. But that presentation is always unusual. See, sinusitis has classical features, classical clinical finding, classical mucosal finding, which is not there in any chronic disease, and that can make you suspicious, can take a biopsy, and tuberculosis is very well medically treatable. So we have seen tuberculosis, not
Yes, sir,
very common.
Those patients used to complain of like mucormycosis like symptoms. So
Yeah,
we
so there
send
are
it.
unusual problems. I told you, sinusitis has a different symptomatology, different appearance of the mucosa, everything, predictable. But something unusual, you need to take biopsy and confirm and direct the treatment. That's why I mentioned in the MRI also, if the patient presents with some abnormal symptoms, which is not correlated with the sinus disease, not correlated with your endoscopic finding and endoscopic picture, must get MRI done. MRI by virtue of various, ability to give various sequences, you can pick up such unusual diagnosis much easily than CT scan, which just gives opacity, cannot differentiate between soft tissue.
Sir, a slight deviation from the topic. Regarding DCR, I would like to ask, do you intubate?
Yes, we do all under general anesthesia, all nasal surgery under
No,
general
no, not endotracheal, like lacrimal intubation.
Not really, except in revision situations, sometimes you have a very, very fibrotic wall. Because we marsupialize, not only, we just don't open the sac and come out. We marsupialize the entire nasolacrimal system. We go above the level of the common canaliculus to the dome of the sac, which is almost 5 to 8 millimeters above the level of the dome of the sac is above the level of the common canaliculus. So right from there till nasolacrimal duct below, we marsupialize the entire nasolacrimal system on both sides like an open book. You don't leave any raw area, and it doesn't direct you to use the all those cannular stents or all those things.
Reserved for revisions only.
Very, very rarely.
So in a patient whose one eye had a revision and we intubated, the other eye we are doing for the first time. Should we intubate prophylactically?
Not really. See, even in the revisions, if you do a proper marsupialization, you don't feel like using the stents, and self is a problem. So unless you can't help it become so fibrotic, you don't need to do anything.
When very small sac, sir? But like
Yes, if
lacrimal
you do a
sac.
good marsupialization, you can follow it. You can, do a regular syringing for some period of time to flush out anything blocking, rather than prophylactically intubating it. Prophylactic intubation, I don't see any advantage.
So status of steroid-eluting stents.
Yes, I have kept in one of the slide in my presentation post-op care. So steroid-eluting stents were introduced and approved by the FDA also. The Propel is the stent which has been approved by the FDA. It, on a periodical basis, it keeps on eluting mometazone. So it is a biodegradable stent. It's like a spring. It serves dual purpose of keeping the ethmoidal cavity open and keeps on eluting the mometazone from time to time. So it's good. It elutes the steroid, keeps the cavity open, and then degrades itself. You don't need to remove it, after a period of time. But the cost is a limiting factor, and still you need, saline irrigation and all that to improve the mucociliary clearance. So because of the cost and not having any significant added advantage than the douching, this have not gained popularity. A Propel costs around nowadays probably $900 or something for a month, which is not a viable thing for a CRS patient who requires, majority of them require a lifetime follow-up and irrigation and all that. In a country like ours, it is not a viable thing, what I believe.
One more question I had regarding anterior DNS. We get to struggle in that. So how to efficiently manage anterior DNS especially?
Same endoscopically, you can refix to the opposite side and to the intranasal spine. So it doesn't fall back and you can go ahead.
Okay, sir. Thank you.
So I think this is the time you can go for a lunch, and I'm coming over there, and in 15-20 minutes we can start our final session. I think the lunch is served there. Anybody from Sipla? Has lunch been served?
So one more point, just out of this contest, can you tell the younger doctors, postgraduates, or the one who has just finished and started practice regarding the consumer protection? If you can give some guidelines, that will be very useful to them, because Of late I have seen, at least our part is over, but these youngsters are very worried about this legal proceedings. So can you really highlight just 2 minutes of yours?
I mentioned couple of times during presentation that there are a lot of issues which can be medical legal, and the thing which protects you is the good radiology and good documentation and patient shared decision making with the patient, because nothing is hard and fast in management. You have to choose the best way, and that has to be communicated well with the patient, given all options. Surgery is the best answer still if you want to continue with the medical treatment. These are the adverse effects. These are the pros and cons. That's it. Don't try to impose, because this disease, what I mentioned, less than 10% of the patients are coming to ENT. Rest are being still managed by the GPs and family physicians and pulmonologists, with the medical management, though may not be, evidence-based, but, they get symptomatic relief and it is something going on. So you have to be following the evidence-based medicine, shared decision-making, documentation, good understanding of the disease and the radiology. That can prevent you, to getting into all that litigations. And surgery, obviously, the radiology is a big role in preventing complication, pre-operative preparation. All those are important. The single most important factor in preventing intraoperative complication is the visualization that is best given out by the pre-operative and intraoperative preparation. So don't rush for that. Operating every patient fast, prepare adequate. Sometimes I've got to know the patient, tell that we have to operate fast, the patient may run away, it becomes symptom free. When you give steroids and antibiotics, you have to tell them, make them understand, we'll operate once you become symptom free, you feel like you're normal, so that we can execute the best surgery. It's all counseling and shared decision making.
Well taken points.
So let's meet after the lunch, and you can meantime have your lunch, and then we'll start our next session. Thank you once again.
Thank you, sir. Thank you very much.
Yeah, good afternoon, delegates. The lunch is just outside of as yesterday we was having. We have forwarded one link.
बिल्कुल जोर से ले वाह